are going to have a very brief discussion about what's coming up with transition. I've had a number of emails from different people at sites over the past few months. So we pulled our team together and said, let's get together and have a chat about this. So let's see, Misha, if you could get to the slide with the outline, please. Okay. So what I'm going to do is a brief review of the study design for those of you who may be new to Compass and may not have seen this. And then Sarah's going to lead off with giving us some data perspective on the current status of the study. And then Misha's going to be talking about some expected transition dates. And then finally, Sylvia and Rika are going to be talking about the all-important intervention team training. So then we will open up for discussion and questions. So next slide, please, Rika. Misha.
Sorry, I'm multitasking. I might go ahead and just mute some of the lines because I'm getting some noise. I just wanted to let folks know that we'll unmute when we go to the Q&A session.
That sounds great. Okay, so this is just a brief review of the design and aims of the studies I mentioned. And the important parts here is that, as I've spoken with many of you and you've heard a number of times, this is a pragmatic trial. And the hospitals are randomized and not the patients. And that's what drives the statistical power. And those patients that are eligible are all stroke and TIA patients discharged home from each hospital. So our primary aim during phase 1, which we're in now, is to determine the effectiveness of this study versus usual care. And as all of you know, you have been actively involved in collecting and enrolling patients in usual care. And we're looking at the stroke survivor functional status at 90 days post-stroke. And then the secondary aim, which is also measured during phase 1, is to assess the caregiver strain. And we talk about that every month. And over time, we have seen that there has been some improvement with the outcome data, and we're still working towards improving that caregiver information. But again, this is important because it's one of the secondary aims of the study. We also look at all-cause readmission at 30 and 90 days, and then we look at mortality, healthcare utilization, and the use of those billing codes, and those are for the intervention sites. Again, this is just a graphic of that where you see yourselves right there in usual care in year 1. So you may remember that wave 1, there are different waves that were launched in usual care in the first year. So wave 1 was launched in August, wave 2 in October, and wave 3 in December. So that's going to inform how we look at the data and make our decisions about transition. So now I'm going to turn it over to Dr. Sarah Jones to talk about our enrollment and outcomes ascertainment.
Okay, so this is going to be a brief update on how we're doing in phase 1. We are already at 3,300 participants enrolled, which is really excellent, right on target. So congrats to you all for working so hard to make that happen. Our enrollment goal, and as a reminder, is 6,000 participants. And just some background on where this 6,000 came from. The goal was to achieve study power, and that basically just means that we have precision of our study results. So we have some confidence that our findings, whatever they may be, are not chance because we had a small sample size. And Laurie alluded to this earlier, one of the other components of calculating study power for this particular study is that it's clustered by hospital. And so the best power we'll get is when we have the same number of participants from each site. Obviously, that's not going to work out perfectly because we have a large variety of stroke volume across all the hospitals. But we're able to achieve that by stopping and starting certain hospitals at different times. And the largest predictor, I think, of time in phase 1 is really going to be when you started. People who started earlier will be transitioning earlier. And so we've done calculations to figure out exactly when we'll reach our 6,000 participants. And I think Misha is going to share that in some of the future slides. Won't get into that. And then one of the other factors that we considered when we put together the phase 2 transition plan was something called generalizability. And this basically means that we wanted patients from all hospitals to be represented in our final analysis. We didn't want the high volume sites contributing 50 or 60% of the information to our study, because we wanted our findings to be generalizable across different clinical settings throughout North Carolina. And so we have really good balance, I think, across our hospitals with the transition plan and how we've launched people in waves. So those sort of the theory behind our different waves and our transition plan. And I think Laurie also mentioned this earlier, but I'll just as a reminder, phase 1 is our randomized portion of the study. This patients who are enrolled in the phase 1 part of the trial will be those that are analyzed to look at our primary aim, which is functional status, see if the intervention is effective at improving patient functional status, as well as some of the secondary, a priori secondary aims that we're looking at. We have other important things we want to look at in sustainability, and I'm sure that'll be a subject of future calls, but that's what we're looking at in phase 1 for these first 6,000 participants who are enrolled. All right, so I think Misha is going to talk now about oh, we do have one more slide. So this is a reminder of all the participating hospitals, and we see, you probably see yourselves on there somewhere. The different colors are regions that are defined by kind of rural urban codes based on population and commuting areas. And we see that we have a great representation of hospitals across the state. We've got Western hospitals, Eastern here in the Triangle region, rural and urban. And so I think this just makes the study so strong because we have great generalizability to all of these different clinical settings.
Excellent. Thank you so much, Sarah. So the point of kind of giving you some of those background slides, and I'll move on to the next slide here, is we wanted to give you a little bit of background about what's been going into the decision for when exactly for sites to transition. We know, we've been hearing, I've been hearing that, there's a number of people who are interested in the details of that, and we wanted to give you kind of the broad brushstrokes details of that today on this webinar. Of course, as we move forward and everything gets refined, we will continue to do that and open this line of communication up to answer any questions. So we wanted to definitely let you know where we're at today, give you some general ideas about the timeline, and then of course that background information, which was Sarah and Laurie have just kind of highlighted, is just to kind of remind you about why we're making certain decisions the way we have with regards to the timeline. So it's very important that we, of course, hit our target enrollment numbers. And then because you all have a diversity of, we have such a large diversity of hospitals, we want to make sure, and we're trying to keep this the balance between the number of patients at each site. It has really been, just a full team effort to determine kind of when the best time to transition everyone over is. So without further ado, we wanted to let you all know that right now it's looking very positive to have, and rather than in 3 waves, we're going to have 2 waves. We're kind of referring to that as a Wave A group and a Wave B group. So phase 2 transition will happen in either one of those waves. So our Wave A group will be transitioning a little bit earlier, so we're real excited that we're seeing that that's going to happen starting the fall of this year. So we'll give you some dates right now around that transition. We'll give you, some general guidelines, and then let you also know our plans for when we're going to be solidifying all the dates. And then once we, a little bit later in this presentation, I'll hand it over to Sylvia and Rika, who will tell you a little bit of just the broad brushstrokes of what's up and coming. And then the second wave, which will be kind of our late wave or Wave B, that transition is going to be happening in early 2018. And so we'll give you a little bit of information too on as far as the timeline for that. So again, we're just going to look at Wave A, which is the early group that'll be transitioning over. And again, these dates are very broad brushstrokes. So July 13th, we wanted to let you all know that we are having we're referring to it as our data retreat. Basically, the executive committee for the study is going to get together, take another look at the data. We monitor it, of course, on a weekly basis. But this is going to be, a very lengthy kind of face-to-face meeting where we will really firm up the plans for this Wave A. So that data retreat right now, the schedule for that will take place on July 13th. So that's coming up very soon. And then after that meeting, we'll have confirmation and final determination on who will be transitioning in that Wave A group, that early group. So you should expect a memo shortly after the data retreat. And we're thinking that will come out no later than mid-July. And that memo will be sent out to each site, both Wave A and Wave B sites. Here on this call, it's just our usual care group, but we're also going to send out a memo to our intervention sites that are going to be transitioning over to the sustained phase along that timeline as well. And then between August and November, if you are assigned to the Wave A group, we'll ask you to complete phase 1. There will be a brief time where we're going to go ahead and we've decided that we'll push pause and we're going to be stopping enrollment for phase 1. So that'll give you and your site and your team a little bit of time to kind of dedicate towards preparations for transitioning over. And then in around mid-August, we'll initiate some one-on-one conversations, probably with you and other key team members that we need at the table as we're discussing the intervention and how to set that up with preparation for phase 2. And then by October 1st, again, the dates here are soft dates, so these are just setting up a framework here. But around October 1st, we'll ask that Wave A hospitals have identified their team and their staff. And again, when you get for future communication with the memo and also on the one-on-one conversations, you'll be fully prepared to know what type of staff members to bring on, and then what will be needed for the COMPASS program at your site. And then mid to late October 2017 is when we're right now planning on the Wave A hospitals to have we refer to it as our boot camp training. I'm sure you've heard that before in other sessions. So we're looking right now at dates for the boot camp training around in the month of October. And then we follow that up with a site-specific training, which we call the site-specific engagement trainings. And I'll let Sylvia and Rika kind of tell you a little bit more about that. So that'll be shortly after the boot camp training. And then, of course, after you're fully trained and ready to go, we would get your site launched up for the Compass intervention. And we're thinking that's going to happen in either late November or early December, around that time frame. So for Wave B, that's a little bit further out, but the process will look very similar to what I just highlighted on the Wave A site. So those sites, of course, would get a memo. Again, that will go out after our data retreat in July. And then in the wintertime, we would begin to establish those one-on-one conversations with Wave B sites, just to make sure that we're getting you all prepared and set up for success for that phase 2 transition. And then right now, even though it's a little bit further out, we're already starting to investigate some boot camp trainings for that second wave, and then our site-specific engagement trainings as well. And then we're looking at a launch in March to April, somewhere around that time. So very early spring, launching the Wave B site. And again, there's some caveats there that this is all approximate. We're working on, of course, tracking the number of enrollments and outcomes. So we did want to, share, of course, that important background information, because those are important targets for this study. And you guys have been making incredible progress. So we also want to, some of you are approaching your 1-year mark. So we want to make sure that we're transitioning sites as they have contributed their enrollments to the overall study. So I believe the next slide is going to be handed over. Here, I'll go ahead and go on to the next slide. And I'll hand this over to our Director of Implementation, Sylvia, and Rika to go through these slides.
Okay, thanks, Misha. Laurie and Sarah and Misha have given you some great background to bring you up to where we are now to talk about the training plan. And I know that some of you were hoping to be an intervention hospital first. And for whatever reason, fate would not have it that way. And we've talked about that and how for the various sites, it ended up being good that you were in the control site first and to get up and running. But now I hope those of you who were hoping to be intervention first are getting really excited about that coming up for you in the near future. And those of you who are newer control sites and might be just getting through what it takes to be a control site and might be a little bit anxious about what this means for you, Rika and I want to assure you, and the rest of our team to assure you, no need to be anxious, because it's very exciting to be to this point, to cross you over from control to intervention soon. And we have plenty of training prepared for you that will make sure that you are ready, and we will support you every step of the way. And as Misha mentioned, we have several components of that training plan, and the first is a boot camp training, and then we will help you build what we call a community resource network development. And once we have completed those 2 steps, we'll actually come out to your hospital, your community, and do what we call site-specific training. And we will start preparing you for all of this probably around mid-August. We'll set up conference calls with you and your team members, whoever you identify needs to be on the calls, and we'll begin to talk very specifically about your site and about how you're going to put the implementation, the intervention model together right there at your hospital and in your community. Prior to ever coming to boot camp, we'll talk some more about it there as a group with others who are in similar roles to you, and then we'll continue working with you to build your network that involves hospital and community key leaders before we come out and do the site-specific training. Amisha, if I could get you to go to the next slide, please. And so let's start with the boot camp training. You will come out with your post-acute coordinator, and that is the nurse part of the key role with the study, and your advanced practice provider, and at your site, and we'll talk about who might be good to fill these two key roles, but it might be a nurse practitioner or a physician's assistant, and in some cases, maybe even a physician, but we'll have your post-acute coordinator and your advanced practice provider come to this training, and sometimes there are tag team roles, and if so, then we would invite those people that might be going to share a role with you. And we will do, we have gotten this down to a 2-day training, and we promise you that it is some work. We call it boot camp, but we're not exactly going to have you on a ropes course or doing push-ups or anything like that. It's a lot more fun than that. We spend the first day going over with you the full model, and we have a lot of experts across our COMPASS team, those that are here at Wake Forest Baptist Medical Center and at UNC that you're hearing from today, but we also have lots of other experts that serve on our larger COMPASS team from primary care, from caregiver experts, from pharmacy, and so on and so forth, that will come in and spend some time talking with you that first day about all of the parts of the COMPASS model and the intervention. And then on the second day, we will have some hands-on where we, as an intervention site, you will have an iPad. We'll show you how to go through the assessments and all of that. But we also, when last year, when we trained the intervention sites that are going through the model right now, they mostly heard from our study team. We did have a patient and a caregiver panel, and that was very powerful. But we have some sites across the state now. We have 20 sites that are doing the intervention, and we're looking at some real treats for you all to actually have those folks come in and talk with you too about what it's like to start from the intervention and build from the ground up. So we have some really nice plans in store for you. And at that particular training, you'll get the intervention training manual, and we will give you all sorts of other information on what it takes to implement the model before we come out and do the site-specific training. Next slide, please. And I mentioned the Community Resource Network development. This is the group of key leaders in your community that make up parts of the medical model as well as the community-based resources. And these are, we have a grid that we will help you when we start these calls mid-August to get you prepared for boot camp training and your site-specific training. We'll give you what we call a community resource grid, and we'll help you start populating it with the key people that are going to help you with implementing the model right there in your specific community. And you're going to know a lot of these people, and you're going to build upon the resources you already have at hand. And you're going to, as you work with these people, you're going to learn about additional resources that maybe from a hospital standpoint, you never really even knew existed. When we did this in our community, we thought that we knew everybody out there in the community that could possibly help TIA and stroke patients going home. And when we had our Community Resource Network meeting, we learned about a lot of other resources as well. So we will help you with that. Next slide, please. And then all of this is going to come together to support the post-acute coordinator or the nurse role in the intervention. And what this does is help to pull together what is called a community resource directory, and we'll have that by county on the website for your site. And so when you go in, you'll learn all about building the eCare plan, and as you do, you will be able to pick and choose resources that are right there in your community to assist patients, and if they have a caregiver, their caregiver, and their family members with finding their way forward to optimal health and recovery. And so you have this to look forward to as well. You'll have, again, you'll build upon what you already have and what you know, but I think you'll be surprised at what we will help you put together that will lead to even better outcomes for your patients. And we will help to keep that updated from our study team standpoint. Next slide, please. And then we will come out after the boot camp and helping you identify who's going to be at your site-specific training. And we will come and work with you over the course of the biggest part of the day of how this is going to work right there at your hospital and in your community. And there are similarities across all of the intervention sites, but there are some differences too, depending on the resources that you have at hand, both within your hospital and in your community. So we'll start asking you to help us identify 10 or 15 people that will be key leaders at this site-specific training, and we'll ask you to help us identify space to hold the meeting and so on and so forth. But all that's to come, and we'll talk more about this in August. Next slide, please. I'm going to turn over to Rika now to sort of just bring all of this into summary fashion for you. So Rika.
Thank you, Sylvia. So just in summary, as Sylvia was saying, you will receive a lot of resources, plenty of training and education to help you make the COMPASS model implementation as smooth as possible for you. But I do want to direct your attention to this graphic on this slide. And one of the things that I want you to remember, and one of the big takeaways I want you to get after this webinar, is that you are already completing parts of the COMPASS model already. So if you look at this graphic, the blue represents what you are doing now as a control site, and the red represents what you will be adding on once you cross over into an intervention site. So as you can see from the graphic, you are already completing case ascertainment. You are already doing enrollment. And we already have our research lab calling your patients 90 days for the 90-day outcome survey. So what you will be adding on once you cross over is that your hospital will now be doing a follow-up call 2 days after hospital discharge. Your hospital will be doing a clinic visit for that patient 7 to 14 days after discharge, and a nurse will be doing a 30-day call and a 60-day call. So those are just the 4 components that you will be adding to what you are already doing now. And I want to direct your attention to the red circle at the bottom. And I do want to stress the importance of the post-acute coordinator role and the advanced practice provider role. If you do not have that identified now, that is something that is needed for crossover and when you implement the rest of the COMPASS model. And if you have any questions about the job description for, I'm looking here over at Sylvia, if you have any questions about these 2 positions, just reach out to Lori and she will connect you with Sylvia, and maybe Sylvia can share a job description for you.
Yeah, thanks, Rika. And I think probably what we'll do is after this webinar, we will probably go ahead and share drafts that we use to help you make some decisions about who might be the best fit for the role. So we'll go ahead and send out the post-acute coordinator and the advanced practice provider job description so that you can be thinking about it. I know some of you have budgetary issues. You need to know sooner than later if you're going to expand a role or create a new position, that kind of thing. So we'll share those with you so that whether you're in the earlier wave A or wave B, it's not too soon to go ahead and start thinking about who's going to fill those roles.
Thank you, Sylvia. So if you have any questions about COMPASS implementation, just feel free to reach out to Lori. and she will reach out to me or Sylvia. So that is it from my slide. I will now turn over to the next presenter.
Okay, Laurie again. So thanks to all of our colleagues there in giving you a brief overview. This basically what our goal today was is to give you an overview of the COMPASS study, especially for those who are new to the COMPASS study, but also to help you to understand how we're making decisions about transition. And again, I want to reiterate the fact that we are really look forward to continue to working with you.